So neurological emergencies, a lot to cover, but a lot of easy stuff. When we think about studying the chapter and such, we've covered most of what's important. Stroke and seizure, right? So stroke, seizure, and then the altered mental status are all things that we should think about. That's going to be the primary stuff that we're studying, but we already covered it in preparatory. If we were going to think about this in a way that was getting ready for the National Registry, what we really have to maybe focus on is being able to compare and contrast a Cincinnati stroke scale, LAPSS, which is the Los Angeles pre-hospital stroke scale, and the men's exam, which is the Miami Emergency Neurological Survey. All right. So all of those things are possible scenarios or involved with scenarios at the National Registry. At the end of the chapter, when it starts talking about muscular sclerosis, ALS, Alzheimer's, Pick's disease, I think is in there. All of those have some importance. A good way to study those would be flashcards, probably, and then you need to know the pathology for those. All right. So very often they are autoimmune system problems, but not all of the time. Is it a brain thing or is it a peripheral nerve thing? The symptoms that they start with and maybe how they die. The way the National Registry seems to ask questions about these would be in the stem of the question, the patient has a history of MS, all right? And then in the actual question then is, how does that play a part in what's going on today? Or how, what symptoms would you expect? What changes for this patient would you expect, and you wouldn't with another patient if they have MS or Alzheimer's or whatever that would be. So it isn't like we have to diagnose it, right? It won't be the presenting this kind of stuff. Guillain-Barré may be a little bit of a diagnosis one, but you're not going to diagnose Alzheimer's or dementia. You're going to have a stem of the question that's going to say the person has Parkinson's. Which of the following would you expect to see? All right, in a normal exam, given that the patient has this history. And then you just need to know like signs and symptoms. Does that make sense? So you won't have to say, this is how I'm going to treat it. Like, I'm going to start putting the person on dopamine or whatever it would be. The other side of that would be the A&P part. So this is a brain, and that's Broca's area. What does Broca's area do for us? Dylan, what is that responsible for?
It's either language or speech, comprehension of language or creation of language.
All right, and then if we were, this is the other one that you just mentioned, right? So Wernicke's does one of those, and Broca's does the other. So this little fissure here, or ventricle, is called the central sulcus, and this one down here is a lateral sulcus, all right? Central sulcus, lateral sulcus. And then on the front side of that central sulcus is the primary motor cortex. Behind it is going to be the primary sensory cortex. And so that helps you figure out which one's Broca's area, all right? So Broca's primary motor, so if that's primary motor, Broca's area helps us produce speech. It's motor, it's a production of speech. If you can understand stuff, but you can't say things, what's the adjective that they use for aphasia? What word goes before aphasia to describe that? You can't produce speech. What is that? It's expressive aphasia. Expressive aphasia. When you don't understand what somebody is saying, that is called receptive aphasia. All right? Something that is, I think, peculiar about all of this is when we're talking about Broca's and Wernicke's area, that is speech, and it has nothing to do with the written word, all right? So when you are taking care of somebody and they do not seem to understand what you're saying, write it down, and they might be able to understand what you're saying. If they don't seem to be able to communicate with you through speech, ask them, do you think that you can write stuff down? All right, would that make it easier? And then giving them paper and pencil might be the best way for you to communicate. A whiteboard and a marker would be cool too. So we need to know your 12 cranial nerves. I don't think I need to spend a lot of time on this, all right? So we've already had the 12 cranial nerves on 2 quizzes. They'll continue to be that way on multiple quizzes. The next quiz may have things like which ones are sensory, which ones are motor, and which ones are both. And the questions are maybe leading towards how would you check them. Checking cranial nerves, which I've been teaching paramedics for a long time now. When I used to teach it as one of these things where I would say, I am teaching above what they have to know, so the National Registry will be easy, all right? Because they don't have to know it. I'll tell you, and I swear to God this is true, there are very easy answers on the National Registry if you just know your cranial nerves. If you just know them, it's 100%, I will tell you that this isn't a waste of time. And now, when you hear me talk about the National Registry, I often say the National Registry likes American Heart. And American Heart has a fairly new course, it's a few years old, it's called the Advanced Stroke Life Support. All right, I would say go to it if you have the chance to go to it. It's kind of a good course, and also talk about a stroke for 7 hours, all right? So you'll know stroke when you're done, but very often the people presenting the course are neurosurgeons, all right? So you'll have a good, deep understanding. Metro or U of M, I think, wants to do some of those. Part of American Heart's course is the men's exam, and the men's exam does cranial nerve exam, all right? A cranial nerve exam has some importance, more importance as a National Registry candidate than as a real paramedic, all right? If you don't ever do cranial nerves as a paramedic, I think that'd be fine. I really don't think it is a more thorough assessment. If you have this inkling to go on to nursing or PA or physician, I think it's a great thing where you're going to get better and better at your assessment as a paramedic. If you're going this little extra step to do a cranial nerve exam, which is not even 2 minutes, all right? It can go really quick.
If you're on the ambulance, you specifically, you have a patient that you're suspecting a stroke, do you skip Cincinnati, BFAST, all that, and just do the cranial nerve?
No, I would go be fast, get the patient in the ambulance, moving towards the hospital, and do cranial nerve.
Do you document that you did both of those, or do you just document cranial?
No, be fast would be for sure what I say. I don't like the term cranial nerves checked and intact. I'll say stuff like and it won't sound like I covered all of the nerves. I'll say eye movement is normal. Eye movement checked and normal, or whatever. However, I felt like saying that. There's absence of, or there's positive facial droop. That's the kind of an assessment of the 5th and 7th cranial nerve. So if you're going for sensation, that's more 5th cranial nerve. And then if you just say, stick up your tongue and that comes out, that's the 12th cranial nerve. And you, instead of me saying I checked the 12th cranial nerve, I'll say something like, patient sticks out the tongue, unremarkable. All right, so something like that, I'll say. It used to be when I was in education, we had one of the paramedics who always said 12 cranial nerves intact. That was just, he did it all the time. He'd just go 12 cranial nerves intact, 12 cranial nerves intact. So I asked him, I said, did you check? And he goes, no, they're probably intact. Why would they not be intact? You know, there's nothing wrong. So You can't do that. You can't say 12 cranial nerves are intact without checking scent, all right? If you say that you did it, then you should have gotten out your alcohol preps and say, can you smell this and can you smell this, all right? When you're doing cranial nerve exams, you are pretty much always checking this side to that side. So if you're checking the scent for olfactory, you want them to close one side, sniff, close the other side, and sniff. All right. This does get a little bit hairy because cranial nerves, for the most part, don't desiccate. All right. Desiccate is like D-E-S-U-G-A-T, and that means cross. All right. Cranial nerves don't desiccate. Here's one that kind of desiccates. I think that's number 2 for optic. And so that ends up being where when we have the, let's go with the facial nerve, all right? Facial nerve, what number is that? 7. When we use our facial nerve, it goes straight from that side of the head, it goes straight forward, all right? So it seems like when we're talking about facial droop, that if that is true, that those just go straight, that this side would be drooped and this side would be weak, all right? But you control this side of your face with this side of your brain, all right? You control, everybody, that's from EMT, right? You control this side of your body with this side of your brain. You control this side of your face with this side of your brain. This side of your brain goes across to talk to a cranial nerve that goes straight, all right? So when we are talking about a reflex arc kind of thing, that is straight. That's where you start to have confounding things, all right? Where you're like, wait a minute, why is that true? Facial droop should be on this side. All of those positives should be on that side. When we're talking about using the brain, it is always true. So this side of the brain uses this cranial nerve and it goes straight forward. But if it's in a reflex arc where you didn't use your brain, then it's on the other side. Does that make sense? So probably not a National Registry question because it's too dang confusing. Most instructors don't know that, all right? So I didn't know that until I went to advanced stroke life support because I was like, this is really confusing me. Why is this true, but this isn't true? And the neurosurgeon was the one who just broke it down Barney style for me and explained that. I have not been able to find that in a written way on the internet anywhere that explains it where I would print it off and give it to everybody. There just isn't a good one, all right? He explained it in 10 or 15 minutes because I just kept on saying why to this guy. He didn't know me, he was like from Lansing, so I was like, I can be as stupid as I want in front of this guy. And he was, I would think, brilliant, and because, for you to explain something, you have to really understand it well, and he understood it really well and had confidence of how your cranial nerves work and how that would, some of the reflex arc stuff wouldn't use your brain. You're not using your brain, then it goes forward, back and forth on the same side. And so here's all the patient assessment stuff. We saw this slide before, this mental status exam, the MSE, that I think I probably told you this before, that this was just something that the author used. The mental status exam was the way they described these different things. And it was just the way this author from what was the Brady book, that's what they use. You can see this mental status exam that's in nursing patient assessment. It's in all of the paramedic textbooks, all right? A mental status exam is just like a primary exam or whatever else, all right? This is just that's terminology that they use to teach medicine, all right? Not just at the paramedic level. If you said you did a mental status exam, these are the things that you are saying that you did. Does that make sense? So a general appearance, whenever this used to not like, this wasn't there when I went to paramedic school, all right? There wasn't a mental status, or maybe there was, but it didn't have like the connotation that it does now. When I started teaching this for the first time, which was around 2006 or so, when we kind of switched our general approach, probably even before that, of teaching patient assessment, and we changed our paramedic textbook where patient assessment was one chapter to having patient assessment, therapeutic communication, history taking, and some paramedic textbooks have a whole bunch, like the Brady 5-volume series, it's a whole book that's just patient assessment. And all of the different book carriers have it. There's one that's just patient assessment that you can buy from JD Learning, all right? Or at least you could. Whenever I got to this point, I pictured it as, and this is what they were doing, is they were looking at the expanded scope of paramedics, and that we would be doing triage at urgent care centers. They were thinking that that would be a much more of a flowering thing in 2002 or 2003, where they came up with all of this stuff. So in this general appearance, the way I always see it in my mind's eye is I open up an exam room and I have a general appearance. And almost all of the stuff, when you're studying mental status examination, you'll see stuff. If you just Google, YouTube it, a lot of times they're teaching PAs, nurses, doctors, it's from medical school, it's all of those. So when you're watching the videos, it's a patient sitting in an exam room. But we can do all of these things when we're approaching the patient who's sitting on the sidewalk also. And so under general appearance, what do you think is under there? What do we look at? Let's go to the exam room. We're working as a paramedic, beyond just doing triage, we're going into the exam room to do the primary assessment before the doctor sees them. What does the general appearance, what kind of stuff are we going to pick up? And you said you can think about it in pre-hospital too. What do we pick up in a general appearance?
Skin condition.
Skin condition, good.
Work of breathing.
Work of breathing, so the old triangle type of thing from the, we have work of breathing, skin, which kind of goes with the cardio kind of stuff. And then over here was their mentation. Are they paying attention to you? That's the pediatric assessment triangle. What else?
LOC.
Good. What else? What else can we see when we walk into a room?
Age, weight.
Age, weight. We can guess at their sex or how they identify. Anxiety level. All of these things. What else?
Life-threatening injuries or bleeding.
All right. Life-threatening injuries, bleeding. What else? You're going to figure out, are they taking care of themselves? How dirty are they? How bad do they smell? Are they wearing the same clothes as they were wearing yesterday, more than likely? Are they wearing really heavy clothes? Are they wearing we're in the summer in Savannah and they're wearing what we are wearing now, all right? Instead of like you would expect the patient to be in shorts and a t-shirt and they're dressed with 2 pair of pants on, all right? And 2 coats, that kind of stuff. What would that start to make you think if they were wearing a down coat and it was 70 degrees? What do you think?
Are they cool?
Maybe they're cold. It starts to be psych problems, all right? Where people are detached from reality. That's very often you can see it, like they're just not taking care of themselves. They're overdressing here. Homeless people wear their stuff, all right? So you start to think, why are you wearing 2 pair of pants? Why do you have 2 pair of pants? You're like, that's the easiest way to carry my extra pants. I have 2 pair of pants. I either carry them or I wear them, and today I'm wearing them, all right? So the same thing with extra clothes, extra everything. Have they bathed? All right, do they smell? Are they taking good care of themselves? It goes towards geriatric patients too, who are possibly Alzheimer's or some sort of dementia. They're just not either taking care of themselves anymore, or they're not understanding that it's hot outside. We shouldn't be wearing that much. Or they have myxedema and they're really cold because the thermometer isn't working. So for patient speech, I'm actually going to probably make a photocopy of the psych chapter in this red book over here, because this red book, the best thing about that book, one, I'm one of the authors. Two is, that's probably the best part. Number two is the person who did the psych chapter is awesome. All right, that definitely isn't one person who wrote that book. There, you can just tell by reading it that. And I'm not a good reader. You can tell the writer are different people each time, and they go over that patient speech really, really well. It's something that is therapeutic communication. Nurses kind of get it, but you can get this, and if you're paying attention, you'll pick it up, and you'll be able to communicate it. Where people have things like pressured speech, all right, and when somebody feels pressured to talk to you, they'll immediately follow your question and hurry up and answer your question right away. What will end up happening is their brain has to kind of catch up with their mouth after a little bit. They very often want to just get the answer out and then done. And then that's all they want. Then they don't want to talk again until they have to. As soon as they have that instant where you're done asking the question, they go right back into. And that goes forwards. There's a psych problem with that, all right? There's paucity, where they don't want to talk at all, where they'll say as little as possible. There's things like tangential and circumferential or circumstantial answering, where they will start to answer your question and they will go off on a tangent and talk about something totally different and then come back, and you have to basically get them back to answer the question. Circumstantial is they go all the way around and they come back by themselves and end up answering your question, but it was a yes or no question that was, you were thinking it was going to take 1 second, and all of a sudden you start talking about something for 3 or 4 or 5 minutes. Their affect, what's another way to say affect? Cass, what do you think? What's another way to say affect here? One of the weirdest words in our curriculum, I think, and we use it in multiple different ways.
Is that like how they act towards you?
Sort of. Sort of. Anybody, what is affect? It is the outward display of mood. It's their outward display of what mood they're in. So you can see people will have a sad affect, people will have a mad affect, people can have a serious affect, people can have a jovial affect, all right? So bland affect, all of those are affects, all right? So how is their mood, and that is the visual, not you ask them their mood, is how do they visually look. That is somebody's affect, and that very often is described as maybe pain. You can have a painful affect. Form of thought and thought content. These two, this is what, again, the red book, form of thought and thought content, and then the patient's speech, these kind of go together. And that is this person able to just basically form a sentence, all right? And again, it kind of goes towards that pressured speech when they feel like they have to talk really fast. Is it that they begin talking to you, they seem to know what they were going to say, and then it just drops off? You know, like they maybe started with what seemed like a lucid thought, and then it goes away. And then orientation, that's basically alert and oriented to values 1, 2, 3, and then 4 is they kind of know what's going on around them. And then memory is another thing that is kind of important. It's one of those things where when your brain isn't working right, you will stop putting stuff into your long-term memory. And so when you are telling the person your name, they won't remember your name. And it is one of those things where you, as a paramedic, can easily be able to communicate that to the nurse. This is what's going on. They have short-term memory loss, all right? If we have that with somebody who gets brain injured, it's fairly easy to see. But it is something that we should be checking for everybody who had a hypoglycemic thing, a seizure, Anybody who had any altered mental status, all the toxicology, all of those we should be evaluating. Are they forming long-term memory at all? So here are some of those other assessments. Some of these are memory, some of these are just ability, cognitive ability. And one of them, and something that cops are kind of taught, is first, try to have the patient do two things at one time. Tell them to do two things at one time. So one is going 1, 2, 3, 4, and 4, 3, 2, 1. 1, 2, 3, 4, 4, 3, 2, 1. Explain it to them, show them how to do that, and then see it. This is absolutely what people will do sometimes. All right, or 1, 2, 3, 4, 4, 3, 2, 1. All right, because they're not understanding when you ask them to do two things, and they'll definitely focus on one thing and pick it up. All right. Here, count down from 40 to 32 is kind of saying there's two different things. You're telling them to stop at 32. And so kind of a positive is when they start going 31, 30, 29, 28, and see how far they go down, all right? And then you can either say, you just failed my test. This is what I want you to do, or do a different test, all right? I usually choose not to tell the person that they failed that test, all right? You just say, go from 40 to 32, and if you keep going, I sometimes say to myself, maybe you didn't explain it right. Give them another one to see it and pay more attention to how you're saying it, all right? And make sure that you say it correctly, and very often they'll do fine on the second one, all right? Other times when they're doing poorly on the second one then, or if I do the same one 5-10 minutes later, if they're able to knock it down, and then they say, oh, you know what, last time I was supposed to stop at 32, wasn't I? I went all the way down to 25. What a dope. Those are both positives. They're both negatives, actually. They're passing the exam. And a simple Romberg's test, do you know, remember what a Romberg is? And it's a little bit different, but it is, you can have them hands out like this, but you don't have to. And then this, they should be able to do. Does that make sense? And then the tricky part is close your eyes, all right? So close your eyes, and then when their eyes are closed, you want to be there to catch them if you're going to be doing it while they're standing, all right? So some people will fall fairly quickly, so you want to be ready to catch them one way or the other. A real good assessment of their cerebellum. Repeat this thing, no ifs, ands, or buts about it. There's some difficulty in there, so it's not as easy as saying, what do they say? Something about like the sun is shiny in Michigan or something like that. Have you guys ever heard that? Like some of the neuro stuff taught in Michigan is you're supposed to talk about how sunny or shiny it is in Michigan. How many nickels and 35 cents? Name 10, which I don't like naming 10 of anything. It takes too long. But remember these three things. So what do you guys remember? What do I ask my patients to remember? And the letter M. All right, so football blue and the letter M. I say the same things all of the time, so it comes off my tongue really fast. All right, I'm not thinking and saying, what did I tell them again? So football, M, and the letter blue. I don't say maize, it's always blue. All right. And then a sensory exam, and then palpating down the body, checking the dermatomes. And these two terms you need to know. Anesthesia is the lack of sensation. Anesthesia is the lack of sensation. And paresthesia is pins and needles. So when we're talking about the dermatomes, when we're feeling in this area here, how much of our spinal cord do we use has to be intact for us to feel up here? How much of our spinal cord has to be intact for us to feel up here? Any ideas? Doesn't have to be intact at all. Those are cranial nerves. All right, cranial nerves. So you don't need to have them. You'll still have feeling. You'll still be able to smile. You just have motor and sensation because they're cranial nerves that don't use your spine. Nerves do come up your spine and give you more. All right. So when you're going down the dermatome map, basically, in this area right here is C4. All right. This area right here is C4. All right. C5 is out here. So this is C5. All right. This is anatomical man like this. All right. So if this is C5, this is 6. All right. So C5, brushing off your shoulder. 6, 7, 8, and T1. All right. So a great way to do the test is just come down here and say, can you feel that? Close your eyes. Can you feel that? And you have it all the way down to C8. There's no reason to do all of them. If they're intact down to C8, they're intact. All right. And then the next level really is T1. I'm sorry, T4 is the nipple line. T10 is your umbilicus. All right. So as far as us as National Registry candidates, C8, T4, T10. All right. Your spinal cord ends at around L2. And then after that, you have your cauda equina. And so when you're starting to talk about sacral problems, and I should say lower lumbar and sacral problems, then very often, again for us as National Registry candidates, your legs will be different. All right, you'll be able to feel to the knee on this side and down to your ankle on that side, or on the motor side, if dermatome is sensory, on the motor side, it's what is that mapping called? Yeah. So the motor side of the dermatome. So when we're checking motor, it's move the hands and fingers and feet against resistance. We're used to doing that, right? So push on the accelerator, lift up on my hands. If we're here and we want to be checking C8, is spread your fingers and don't let me push them together, or push your fingers together, spread them apart, and you're testing there. All right, so you're down to C7, C8 when you're doing that. And now, if you're touching them, can you feel me? Yeah. All right, I'm going to hold your fingers together. You spread them, or I'm going to you keep your hands spread, and I'm going to push these together. And you're probably checking one side versus the other. And you can check coordination after that. What's a good way to check coordination and fine motor? It's probably having them touch their nose and touch your finger. All right, nose to finger, nose to finger. Move your finger a little bit during that time. Again, you're not only looking for their ability to do it, but if they start to shake when they're hitting your finger or hitting their nose, that's another kind of a positive. They shake on one side and they don't shake on the other. What part of your brain are you checking when you're looking at coordination and fine motor control? What do you think, Lena?
Back bottom, cerebellum.
The cerebellum, back bottom. All right, so when we're talking about stroke, I'm going to go kind of quick here. These I think are pretty easy, probably about the same slides as we used before. The men's exam is what we'll try to do a little bit more. I don't do when we're using our little pieces of paper and such. I don't do a perfect men's exam. I just do a Cincinnati stroke and cranial nerve, which is about the same. And then save the penumbra. Hannah, Wordhouse, do you remember what that was all about? What is save the penumbra?
So, when you're having a stroke, that's the tissue surrounding the dead tissue.
Yeah, yep. So when we have a stroke, there's going to be a core infarct that we might not be able to do anything about, all right? And that area right there is going to then have dead tissue, and when we have dead tissue, we have that same thing where we're going to have the loss of lysosomes and maybe high potassium in that area, a change in the pH, all of that kind of stuff can occur. And what had happened in the past, 20 years ago, is it would spread and all of this area would end up being affected. It was the area that very often people from a stroke would have some ability to get better over time because we would be able to get back some of the penumbra. Now, with the more timely use of either thrombolytics or surgery, we are saving penumbras. All right, we're able to give them neuroprotective medications that protect this area. We're able to limit core infarcts to some degree, and we're able to save that whole green area. When you take that advanced stroke life support, the first thing that is important, and it's going to be important at the National Registry too, is we figure out that they're having a stroke. When it's an obvious stroke, we figure it out and we get scooting right away. And we should realize that I think overall in the nation, we are able to diagnose strokes about 55% of the time. All right, so of all of the strokes that we take to the hospital, 55% of the time we're able to say this is a stroke. All right, we do really, really well in the I think mid to high 90s when somebody's having a stroke and we say they're having a stroke, they're having a stroke. That's what we don't mess that up. All right, we mess it up every once in a while, but we're pretty good at it. All right, but we miss 45% of the people who are having some sort of cerebrovascular accident. All right, and so the ones that we miss, what do you guys think? What ones did we miss? What ones did we miss in the past? What is the difference between a fast and a BFAST? That one's you, Pat. You know the difference between a fast exam, which is kind of the same as Cincinnati stroke.
Well, I was thinking the hemorrhagic strokes were the ones we missed.
I don't know if that's true. I don't think so.
Wow. I don't guess.
Not usually. What else? Because those are kind of thought of as the worst one.
Sure.
What do you think? What's the difference between fast and BFAST? All right. What is, Andrew, what does the BE stand for in BFAST?
Balance. Eyes.
So we're doing BFAST because fast wasn't good enough. Would you guys believe that? We didn't just do BFAST because somebody paid a bunch of money, all right? Like Big Pharma took over and now we all have to do BFAST. It was because we were missing strokes, all right? So they told us to do BFAST. So what kind of strokes were we missing if we're now checking balance?
Posterior.
Posterior, which is cerebellar, cerebellar, which is cerebellum, cerebellar. Good. And then eyes would go with? No, kind of. Yeah. 2, 2, 3, 4, and 6 are all checked. What are those? What? These are called cranial nerves. Maybe we haven't talked about those yet. So cranial nerves, where do cranial nerves exit the brain? Jeffrey. Nope. Your brain stem. So maybe I should just say brain stem. Let's keep that off. These are all named from going anterior to posterior, all right? So the most furthest anterior cranial nerve is cranial nerve number 1, and that is your olfactory, all right? One of those things that I don't like when we're talking about these and cranial nerve checks, because it's a bit of a pain in the butt, I say just skip one. when we're checking it. If you want to, you can check it. But guess what? It's not a very vulnerable one. And it's the shortest one. It's most often not going to give you a positive. So it seems like a waste of time. When I'm seeing a whole bunch of other positives, I might go back and say, oh, look at this. Let's try and do this too. But when we're doing eyes, a good assessment of eyes isn't just how many fingers am I holding up, how many fingers am I holding up. It should also be an H pattern to see what's going on. Does that make sense? So that would be a good, thorough BFAST. Just how many fingers, how many fingers. You're only checking the optic nerve with that one. If you're doing an H pattern and watching to see if the eyes are moving together well with each other, and maybe checking to see if one is more dilated or constricted than the other, and reacts the same way to light. If there is one is off from the other, that's now we're checking 4 different cranial nerves while we're sitting there looking at their eyes. So the ones that we very often miss aren't large occlusion. They're not. Large occlusion, I think, are important to pick up because there's a little bit more of an emergency with it. A bleed is important because 85% of them aren't bleeds. So when they are bleeding, then we're able to say, hey, this is a bleed. We're not doing it any routine. You might want to have surgery. We definitely want to go to a stroke center where they can do a neurosurgery, not just a general one where we might be happy with fibrinolytics. So these are the ones that we're missing. So those are the ones where those will pop when we're doing things like looking for just mentation changes, also cognitive decline. Those also could be part of it. And when we have a small stroke, it's easy to see the big strokes, right? It's easy. That's almost all of what we're going to do here. Is the person has facial droop, not talking well, hits the fast right away. Those are easy. Those more than likely are national registry. All right. What do we do with that patient? Like we go in, do the Cincinnati stroke scale. They have this arm drops. They can't say you can't teach an old dog new tricks, and they have a facial droop. What do we do with that patient? Mike.
Rapid transport supportive care.
What do you mean by rapid transport?
Get them going to a definitive stroke center.
Good. So short on scene. It's still priority 2 to the hospital. All right. We move with a sense of urgency. We have urgency because time is brain, just like time is muscle for the heart person. So then what are we going to do? Remind me to talk to Tiffany. So we're going to have short on scene time, move with a sense of urgency. What are we going to do on the way to the hospital?
Check their managed vitals, protect their airway, reassess.
What do you mean by reassess?
So do the same assessment you did before, note any worsening conditions.
Why do we do that?
To see how bad things are.
All
so
right.
If damage can be continued to happen. Things that we didn't see before are happening. As I say, time is great.
Good, good. What else are we going to do?
Call.
Tell them. All right. A stroke alert early. What else?
Take pictures.
Start an IV.
Yes, sir.
Put them on some oxygen. Monitor. I like all of them. Capnography, pulse oximetry, everything. All right. Just in case you see something, check the blood sugar. And then a big thing for us, for 20-minute out of hospital, for us doing our simulations, and for us when we're trying to take the national registry, again, when they're going to be asking us questions on the in the way that we practiced the other day, repeat Cincinnati stroke scales or LAPSS or men's exam. Those have a high priority. All right. I still haven't seen students do that enough. All right. If you do a FAST exam or a BFAST, I can say the same thing about 12 leads. You will do more than one. You should never be happy with one BFAST, never just one LAPSS, never just maybe just one men's exam. All right, you probably do several of them. And one of the big reasons for that is the hospital is going to want to know if they're getting better, that's a TIA, and that's no longer such an emergency where they're going to be given a drug or bringing the patient into neurosurgery. If they're getting worse, it's probably a bleed, and they want to have the surgical team ready for that also. And they want to just avoid the idea of let's start gearing up for this medication that is now contraindicated. It is a timely thing, so let's get our ducks in a row as soon as possible. Everybody good with that? So the reason that we do men's exams and we'll go a little bit further and do a good history is to figure out the non-textbook presentations, which can simply be memory problems. It can be personality changes. That can be a stroke, a personality change, all right? And again, this is just the reality of it, all right? And we can pick those up, all right? And start to say, hey, this is a possible stroke, all right? And possibly save the patient. So here's that men's exam. As far as us, a men's exam is the idea that you repeat your Cincinnati stroke scale, and you're going to start checking cranial nerves. The big cranial nerves are optic. You can say, how many fingers am I holding up? How many fingers am I holding up? Having them hold one eye shut at one eye at a time. And then we'll do the movement of the eyes. I like the idea of having them, you've already had the smile big, show me your teeth, puff out your cheeks. That really is checking cranial nerve number 7. You might have done it quick before, you'll do it during the men's exam. And then if you have them close your eyes, go like this, go like this, go like this, go like this. That checks the facial, all right, or the trigeminal, all right, the trigeminal nerve, which is cranial nerve 5, I think we like to say. I don't do the olfactory, and I very rarely do the vestibulocochlear, which is basically, can you hear this? Can you hear that? Simple one, all right? And then glossopharyngeal and the vagus, we generally don't check those. How do you check the glossopharyngeal? Anyone remember? So open your mouth and say ah, all right? And the uvula will pull one way or the other. It'll pull towards the strong side, pull away from the weak side. And if you say stick your tongue out, stick your tongue straight out. If it goes once, if they do that, and then very often people want to just go poop poop. You say, hold your hand, hold your tongue out. It'll drift to one side. It'll drift towards the strong side. All right. It'll drift away from the weak side. So fairly quick to do when you're doing your quick H pattern. You know, how many? And then you do your H pattern. You go up and just feel on one side. Close your eyes. Can you feel this? Can you feel this? Smile. Smile big. Puff up your cheeks. You've got it almost all done. It's that quick. All right. And that is good. That is good enough to get points on the national registry. It is the men's exam. All right. The only other thing for the men's exam is this. You're checking the cerebellum, your cerebellar check. If you want to do that on the legs, I don't check the legs. You're supposed to do it, I always call it the shin rake, right? You're supposed to put your heel of your foot up on by the knee and then just slowly go down there. And they're usually on your stretcher when you're doing this. You're on the way to the hospital. A men's exam is done on the way to the hospital, all right? You've already figured things out and you're doing on the way to the hospital, reconfirming, or you're moving with a patient who you are looking now for maybe something that is the term that they used was the non-typical presentation for a stroke. So when we have ischemic strokes, again, 85% of them, there could be an embolism or a thrombus. We have to kind of understand what the history would go. If you're thinking the person has an embolism instead of a thrombus, what patient history would that go with? What history goes with an embolism that lodges in your brain? There's one big one. Atrial fib is right. Atrial fib and clotting disorders. All right. Atrial fib and clotting disorders. They take a medication that's for clots. They stop taking it. And then atherosclerosis is the thrombus. So now they have coronary artery disease, they have high cholesterol, that goes with the thrombus side. Hemorrhagic goes with a history of hypertension. They're very often fatal. They're bleeding. Would they be bleeding from a vein or an artery? An artery, right, on the pressurized side. You're bleeding from an artery. And it should get worse for us. The National Registry, boom, it's probably going to get worse in front of us. And so here's those intracranial pressure things. You guys remember, who is it that won $1 million grant just to tell us what's in our cranium? It was two people, Monroe and Kelly. Or else it was one guy named Kelly Monroe. No, Kelly Monroe was Charles Amy, right? So Monroe, Kelly, I think that was one person. Monroe Kelly said, you have a brain, blood, and cerebrospinal fluid inside your cranium. 80% of it is brain, 10% blood, 10% cerebrospinal fluid. We can't do anything about the size of your brain. There's no emergency change to change the size of your brain. There's not a real good emergency change in cerebrospinal fluid. So if we want to change it as your brain changes it, or as we in medicine want to change something, we're going to change the size of the vessels, and that's the amount of blood that's in your cranium. So with an increase in intracranial pressure, so we're bleeding, that's really what we're dealing with now, not the cerebral edema that may be associated with a stroke. I think if you're a neurologist, you might have to worry about that, but when we're paramedics, we don't worry about that, all right? So when we're talking about a bleed, now we have a bunch of blood on the outside of the vasculature, and there's extra stuff in our brain, and we're going to have an increase in intracranial pressure. The brain recognizes that, all right? The brain recognizes that because the brain will start to become ischemic. Less blood will go up there because blood will always flow through the path of least resistance. And if we have resistance in our brain, blood will go somewhere else. Should I say resistance in our cranial vault. So that's called the central nervous system ischemic response. And we'll end up, if nothing goes on, nothing fixes it, we'll end up herniating our brainstem through the foramen magnum, and that usually is not conducive to life. So the things that we have to remember are how we figure out MAP, and then intracranial pressure is usually 5 to 15. I don't mind if you like to say 5 to 10. 5 to 10 is also a good answer. And our cerebral perfusion pressure needs to be 70 to 80. And when it gets in the 60s is when we have problems. So a MAP minus the ICP equals the cerebral perfusion pressure. And so 1/3 the PP plus the diastolic is how we can figure out the MAP. Does anybody know another way to figure out MAP? All right, I like that one. On the next quiz is different. So what is the CPP for a patient with a blood pressure of 129/90? Raise your hand when you got this CPP. One person finally figured it out. Still just one person? Maybe 2 people, 3 people, 4 people, 5 people, 6 people, 7 people, 8 people, 9. What is the CPP? River.
got 46.
It's not 46.
Right now.
So what is the map? If you're 129 over 90, what's your map?
11.
It's not 11. You're using this, 1/3 the PP. So what's the PP?
129 minus 9.
Okay, what is that?
Which is 40, 30, 49.
39.
39?
39. So 1/3 of 39 is
11.
13.
13.
Right? So 13. And then what do we do with that 13?
13.
1/3 the PP is 13, and we add that to the diastolic. The diastolic is 90.
So 103.
103 is our map. Everybody good to go with that? 103 is our map, and then the thing is 103 minus 25. So that's probably 70 something, 78. So 78 would be where the patient is for their CPP, and that means they're perfusing their brain. So blood pressure of 190 over 100, and their ICP is 50, which is a high ICP. One, two, three, 4, 5, 6, 7, 8, 9. And so here, our PP is, our pulse pressure is 90, right? 1/3 of 90 is 30. We have to add 30 to 100. So 130, what is 130? 130 is our map. And then to get our CPP, we have to go 130 minus 50. So what is our CPP? 80. Again, we're perfusing our brain. We need to have that high blood pressure. And then the last one, hopefully, is 140 over 80, and your ICP is 48. And the next quiz will have these. All right? Oh, and they'll be like, if it doesn't, there'll be extra credit. Easy extra credit, right? So here again, the PP is 140 minus 80, that's 60. 1/3 of 60 is going to be 20. 20 plus 80 is 100. 100 is then our map. Map minus ICP of 48 is going to give us a CPP of 52. If you have a CPP of 52, you're not perfusing your brain. All right? You're no longer perfusing your brain. So that brain anoxia is going to kill your patient. So right hemisphere problem is going to give us left side. Easy stuff, right? So the other thing that advanced stroke life support makes a big deal out of is this dysarthria and neglect. All right. So when we were looking at that brain was looking this way, right? Most of us, if we're right-handed, pretty much all of us, our Broca's area and Wernicke's is on the left side. All right, just like that slide had the brain looking at this side, Broca's and Wernicke's. Most people who are left-handed, are right brain dominant, they still have the Broca's and Wernicke's on the left side of the left side of the brain. Some of them, I think it's like 15 to 20% of those guys will have their Broca's and their Wernicke's on the right side. But almost all of the population, when they're having a left brain stroke, they will have problems with Wernicke's and or Broca's, and that will be the terms that we used back then was aphasia, right? Either expressive or receptive aphasia. Here we use the term dysarthria. Hannah Abbott, what is dysarthria?
Like your slurred speech.
Slurred speech is right. Yep. So, and then it is hard to do this, but you're able to do it. This dysarthria is from not being able to control the nerves. Your brain is saying, I want to say this, all right? But you're not controlling your cranial nerves as well as you would like. So when you're talking, it's not coming out the way you want it. That should seemingly make the patient conscious of that and then also maybe frustrated. However, they have something called neglect, all right? And that is usually, if it's a right hemisphere problem, they have neglect. They neglect things on the left side. They neglect things that are on the left side. But they also, underneath the same category of a problem, neglect, they sometimes just don't realize that there's a problem. They don't realize the dysarthria, all right, because they are neglectful of it. And then left hemiparesis problem, left hemisphere problem is that here's where we're getting that aphasia problem, where Broca's or Wernicke's, if that's where the infarct is, that's where they're going to have this kind of problem. And again, that might be something where they could write stuff down or understand written words, but not speech. So the cerebellar stroke is all going to be the fine motor skills stuff, where they're shaking to maybe do this or not able to do the movement from their nose to the finger. And a brainstem stroke is all over the place. It sounds like it's the worst one because it can throw your vital signs all over the place. It could make it so you don't breathe right, all right? Because you're having the problem in your medulla, all right? So this one is, guess what? Probably not on the National Registry, all right? This one presents really, really weird because it is going to do another thing where since at the brainstem is where your cranial nerves are attached to your brain, that also will throw all of those things off. So again, if you're having a small brainstem stroke, you might not have any one-sided weakness and that all of the stuff that we think of for the Cincinnati stroke scale. This might be fine, all right, with no big facial droop or anything. Could be a very small facial droop with changes in the way your pupils work, and that's about it. Complain of sight problems. And here's just another slide that talks about the same thing that I just said, all right? A left brain stroke, a right brain stroke, and then the brain stem. So nausea and vomiting. Why do you think this is associated with this? One word. Vertigo. Why vertigo? In one word. Vestibulocochlear. All right. So speech problems. It's because your ability to use your face, your tongue, your glossopharyngeal, all of those, you need all of those to give you. That's why it's dysarthria, all right, on the other side. But when you have swallowing problems, that's kind of your vagus, your hypoglossal, and your glossopharyngeal are all there. Abnormal eye movements is 3, 4, and 6. Decreased consciousness, and then the crossed findings is because now it is maybe on the right side of your brain. So if it's involving your brain also, it'll give you problems on your left side, but then your cranial nerves go straight forward from where that problem is. So that's now where you're going to have some confusion where you have a droop on this side and weakness on the other side.
Can you have both, like an ischemic and hemorrhagic stroke in the brainstem?
Could you? So anything can happen. But the more like we don't have to worry about it as far as being paramedic students. But the why do you ask?
I think because in my brain, it seems like it would be more likely to have like a clot in the brainstem than have a bleed.
Um, the brain stem has really good, and anatomically wise, has really good like backup systems. So all of them should be, it should be rare to have a brainstem because more than one thing has to happen. Does that make sense? The I would think that the ischemic would be more of a chance, the embolic and the other, more of a chance than having the hypertension causing the bad artery. Does that make sense? Where the other places where you're just talking about aneurysms that were always there, they had a Berry aneurysm that has been there forever. I don't think those are normal here. And we know this one, Cincinnati stroke scale. When we look at this LAPSS, let's just get a little bit bigger here. We have to know these things, all right? 100% on the National Registry, there's a question that says, which of the following is not on the LAPSS, all right? Or it says something like comparing it or contrasting it to the Cincinnati stroke scale, how is it different? Here, so it's an age thing, it's a history of seizures, it's the what their blood pressure is. All I should say blood pressure because it's not there, right? That might be the wrong answer stuff. When you think about Cincinnati stroke scale and the LAPSS, which one do you think more accurately finds stroke patients? Which, in the way that they may say this, which one is more specific for stroke? Andrew, what do you think? Is it LAPSS or Cincinnati stroke scale better at telling you, yes, this is a stroke?
Cincinnati.
Close. So it's LAPSS because here we start to rule other things out, all right? Most of the time, people who are younger than 45 don't have a stroke. It's possible for them to have a stroke, right? But it's not as likely. Here, a history of seizures and epilepsy, when you come across the patient presenting like a stroke and they have a history of seizures and epilepsy, it is more likely that they're post-ictal and they're going to get better and they're not really having a stroke at all. The symptoms are shorter than 24 hours and they're longer than 24 hours. It is more likely a stroke, right? Not a TIA. At the baseline, the patient is not in a wheelchair. So when they are in a wheelchair or bedridden and all of a sudden they have weakness on one side of their body, guess what it can be? It's from sitting in a wheelchair for 24 hours a day, all right? So those people can be just sitting on a nerve or they're not moving off their nerve the way a normal person would. So we're ruling that out also. With the blood glucose, we're saying the blood glucose isn't too low or too high, which is causing the problem with our altered mental status. So that is another thing where we're getting rid of it. So that's not going to be one of the things that mimic a stroke. And then they have obvious asymmetry in any of the following 3 exams. So 6 just covers these 3 things. Their facial, their grip, and then their arm strength, which these things are together. So what isn't in here? What isn't in here is you can't teach an old dog new tricks. All right, so that isn't in here. Grips and arm strength, I think, are about the same. I think there's a weird thing about the LAPSS. Oops, sorry about that. And now, I can't go backwards. So because I'm recording it. So we missed the slides. What is this? What is this here? When we just look at this, what is this for?
stroke?
It is. Tell me more. Go to the bottom, like the bottom half of it, maybe. What are they trying to figure out there? When you're asking those questions or doing these assessments, what are you figuring out? This is a fibrinolytic checklist again. All right, so if they have, remember we saw this before, if their blood pressures are different in their arms, we're worried about them having a thoracic aneurysm. Is it a central nervous system problem? Again, recently. And then here's their blood pressure. If their blood pressures are too high, we can't go the fibrinolytics. So it's a fibrinolytics checklist. Here's the other things. These are all in your book too. So they've had a significant head injury. CPR, remember, was one. They've had bleeding in the brain. They have a clotting problem, or they're on blood thinners. The time the patient last known, if that was outside of, the old number was 3 hours. Now it might be all the way out to 6 hours. Then you're not supposed to use thrombolytics either. And how is their blood glucose? Making sure that we've ruled out all of the other stuff and we're looking at giving this person TPA. So for headache here, I do not have a lot of questions on quizzes or tests on headaches. The very limited stuff that you really have to know. Tension headaches are the most common kind of headache. It's caused by muscle contractions attributed to stress. Does anybody here get tension headaches? Tension headaches. Pain is usually described as squeezing, dull, or ache, kind of all over the place. And what we for roll. Why doesn't this work?